Hi, everyone. This is Krista Martel with the Well Project, and I'm excited to welcome you to our webinar today, Breastfeeding and HIV, What We Know, and Considerations for Informed Choices. We're just getting started, and we're going to wait a couple minutes to have other people join on, but just wanted to get us started. If you're online and you want to put a message in the chat box of that you're here and where you're from, that would be great. Welcome. Hi, everyone. This is Krista again with the Well Project, and we are just going to be getting started here in a minute. We are using a new platform, and as many of you know, we've previously used AnyMeeting, and we're looking. I thought the chat was open to everyone, and now I'm seeing that you may not have the option to chat, which I'm going to try and see if I can figure out. Hopefully you have the option, though, to pose a question. Oh, I see. Let's see. Okay, I'm seeing people say that they're here through the question. Thank you. Hi, you guys found a way around it. So, yeah, so I guess maybe we'll use the question area as our chat box. So, you know, you can put in your question there, but you can also just send a message to the group to say who you are and where you're from. Okay. All right. Well, we will get started, and we will keep looking into this chat situation to see if we can make it easier for everyone. Because I'm not sure if only the presenters are able to see the questions. So if that is the case, then we're going to keep looking into ways that we can create a chat area. All right, but we are going to get started. And again, welcome to our third webinar for 2018. This webinar is Breastfeeding and HIV, what we know, and considerations for informed choices. So our agenda for today is that we'll quickly introduce who's going to be on the webinar. We have two women who are going to share their experiences with HIV and infant feeding. We're going to talk a little bit about the research that we have around transmission and breastfeeding, and then we're going to be talking around considerations for breastfeeding, including guidelines and risks and benefits for having informed choices. Then we'll have a roundtable discussion, and we'll also be answering Q&A from all of you. So we welcome your questions throughout. So we're very excited to have such an esteemed group of presenters today, including Lena Serghides from Toronto General Hospital and Research Institute at the University Health Network. Also, Dr. Jenell Coleman from Johns Hopkins University School of Medicine. Claire Gasamagera from International Community of Women Living with HIV. Jessica Whitbread. And my name is, again, Krista Martel. I'm the Executive Director of the WELL Project. And I'm going to also ask Shannon Weber, who's co-moderating for this webinar, to quickly give herself an introduction.
Great, thank you so much. I'm Shannon Weber, and I'm Director of HIVE.
Thank you. Okay. So just a quick overview of the webinar, that it will last approximately 90 minutes with Q&A, and just again, we're figuring out the chat box, but you can use the question area to enter in questions. We'll be putting those in a queue to be answered at the end, and your lines will be muted. I think if you have, you can raise your hand in the webinar if you have a question and you would like us to unmute. We will be doing some live tweeting from the webinar. If you are also inclined to tweet anything that you're a takeaway during the webinar, the hashtags that we're using are breastfeeding and HIV and hashtag the WELL Project. So WATCH is our Women's Advocacy and Treatment Coalition on HIV. It's an ongoing HIV treatment advocacy and capacity building webinar series. We typically do around 3 to 4 webinars a year. And so far, this is our third webinar from 2018. If you go to our website, under the HIV information, there is a drop-down menu, and there's webinars, and you can access our past webinars that are recorded, and the resources that are available around those webinars, including slide sets and different additional resources. So this webinar is also going to be recorded and will be available on our website after, probably within a few days. We'll also send out an email to all the registered participants to, when that's available, and a link. And certificates for completed webinars are available upon request. Okay, so with that, I would love to jump right in. And so again, I'm going to ask our first speaker, Jessica Whitbread, to just introduce herself, and then she's going to talk a little bit about her personal experiences.
Hi, everyone. My name is Jessica Whitbread. I've been doing global HIV advocacy for the last 10 plus years from my home in Toronto, but I'm currently living in Central Asia, in Kyrgyzstan. And but what I'm talking about today is part of my personal advocacy story. So my journey with breastfeeding and HIV realistically started about 18 years ago when I was diagnosed. I think for many women, like myself, when you contract HIV in your reproductive years, part of your thoughts are about future or current lovers, and the other part is about future or current children. And at that time, I remember being told there was a 1 to 2% chance of transmission during pregnancy, and I don't even think we talked about breastfeeding because it wasn't even on the table. So let's fast forward about 15 years, and I find myself pregnant. So this was 3 years ago. And once I decided to proceed with the pregnancy, I needed to develop a care plan with my partners and healthcare team for myself and my twins. Yeah, twins, right? Luckily, I've been doing work in global advocacy on reproductive rights for women. So I had been aware of the most recent WHO guidelines and other current research saying that, well, not zero chances of HIV transmission through breastfeeding, while being undetectable, were low, around 1%. What I also knew was the part that really made my blood boil, and that was that many women living with HIV were forced to secretly breastfeed, unsupported and alone, and many more had their children taken away because healthcare providers had reported them for negligence to public health or to child protective services. I decided to use my pregnancy as an opportunity for social change and advocacy. I wanted to be able to do something unheard of in a Canadian context, and that was to openly breastfeed my babies as a woman living with HIV. But in order to do this, I needed to get a care team that supported this decision. I was very open with my doctors about my intentions, and while hesitant, my circle of care developed a plan to support me and created a larger plan that could possibly support other women and their choices if they decided to breastfeed in the future. And I give them full credit for their innovation and really being forward thinkers in this regard. In addition to that, I have to say that I had this really deep conversation with my partner, and I think it's the one that most women living with HIV have. It's the what if conversation. So one day, me and my partner sat down and I laid out all the information I know about pregnancy and breastfeeding, including potential transmission, because he's negative and I'm positive. So for the most part, he just goes on what I say. And so I said, what if something happens? And what if the babies get HIV? And his reply was really beautiful. He said, then the baby will be just like the mom, and that's not such a bad thing, is it? You have HIV and you're amazing, and if our baby has HIV, it will be no one's fault and they will be amazing too. And I think it's actually his answer that really made me feel safe in our joint decision making. And while HIV transmission was not ideal for either of us, we did not want to feel the stigma around HIV by acting like living with HIV was the worst thing in the world that could potentially happen. So my story in regards to breastfeeding is long and complicated, so I'll jump over a bunch of parts. But basically, I went into labor 2 months early, and the plan to breastfeed was stopped because now that there are so many doctors and nurses involved in the neonatal intensive care unit, that people's judgment could not be controlled. And it was basically unsafe for me to do so. But after a month of me holding the babies and crying in the hospital, my care team sprung into action and called the head of the NICU unit. And by the end of the day, everyone was reading the WHO guidelines and most current research. And I started pumping the next day to express the milk. And while I was not allowed to breastfeed in the hospital, I was supported to do so at home. Not totally ideal, but when you're changing a system, being the first kind of sucks. And it did. It was lonely and hard, and the system was unable and unprepared to deal with an HIV positive breastfeeding mom, like where to store my milk in the hospital and the mixed feelings about getting a biohazard bag. But I did it, and I'm happy about it. But there's a bunch of other things that happened that felt out of my control as well. Like I had to give the twins treatment. I didn't want to give it to them because I knew deep down that they didn't need it, and I fought with the doctors about it, especially the amounts that they were being given. But my hands felt really tied in order to be allowed, quote unquote, to breastfeed. Myself and the twins were monitored weekly for the entire 3 months that I was breastfeeding and beyond. And it really wears on you. That kind of constant surveillance and ongoing advocacy is draining. On top of sleepless nights, of having newborn twins, the joys of postpartum depression for anyone who's ever had that, and the trauma of 2 months of being in the NICU. I also decided to mix feed my twins so my partner could help me as well, because I didn't produce enough milk for two, almost, but not quite. But the final part of my story that I wanted to share is that although I did collect the best team in Toronto to trailblaze with, but it wasn't without other people's judgment and pushback for all of us. And ultimately, someone did make a report to public health. I do think shame on them for thinking that they knew what's best for me and my children. Shame on anyone who does not believe that women living with HIV are capable of making an educated, informed decisions. I do want to end with breastfeeding. Breastfeeding, going this route was really hard, and it's not for everyone. But women living with HIV should be supported to make decisions that they feel is best for them, their children, and their families as a whole, which may or may not include breastfeeding. But not supporting women to give them agency, larger issues can occur, like unintentional transmission, loss of follow-up to care, and severe damage to women's sense of self-determination and esteem. Because honestly, we all kind of screw up our kids a little, and I'd rather be the ones for them to tell me when they're angsty teenagers than someone else who doesn't even know us or our situation before I even start. Thanks.
Thank you so much, Jessica. It's very empowering to hear you discuss your process and your partner's support. And so, Claire, I'd like to hand it over to you.
Thank you. My name is Tuishime Claire Gasamagera. I'm a person born with HIV, and now I'm a mom to a 14-month-old baby boy, and I'm expecting another baby boy in March 2019. My journey as a person born with HIV in the 80s was not easy. I am a survivor. HIV treatment works. I live a healthy and productive life with HIV. I have always been haunted by the idea of bringing a human being with HIV in this world. I lived with my partner for years, and it wasn't 2 years ago that we decided to start the journey of having a kid. As a child born with HIV and as a woman, I always remember that in the beginning of HIV treatment, we didn't have medication for children and women, simply because children and women were not part of researches. It wasn't until women and mothers stood up that we finally got HIV medication. That time I was a child and I didn't have medication. There's nothing women and children have got in the AIDS movement without a fight and a sacrifice from women living with HIV. I'm an African mother, an immigrant from Africa living in Detroit. My cultural heritage makes me feel less than a mom if I cannot breastfeed. Way before I got pregnant, I started asking questions about breastfeeding, but the answer was always, we don't have enough researchers, we don't know. In developing countries like United States, women living with HIV are instructed to exclusively not breastfeed. Some healthcare providers play the police card, sowing terror in women in case they may be suspected to breastfeed. As a result, we lie to them. We don't feel comfortable with them. In some cases, healthcare providers have reported women living with HIV suspected to breastfeed, and their children have been taken away by the Child Protection Services. As a mother, this is heartbreaking. When I was announcing this webinar in my social networks, I received private messages from women living with HIV who are even scared to be on this webinar in fear that having their babies taken away. One case in Detroit, where I live, a woman I know very well was suspected to breastfeed and was reported by a healthcare provider. Right now, they're in the process of taking away her children. On the contrary, women in developing countries where I come from are instructed to exclusively breastfeed. We have conflicting information on breastfeeding for women living with HIV. Researches we have are based on developing countries only. While I acknowledge the limitation we have as women living with HIV to enjoy breastfeeding, I strongly believe that breastfeeding is not given much attention in researches compared to researches related to men. Women living with HIV are not given enough information on the risk of breastfeeding. Some healthcare providers are policing women instead of providing a supportive environment, trying to understand the issues of women living with HIV with infants. When I had my baby, it was really tough. He spent 3 weeks in the NICU, and when we got back home, for the first 3 weeks, for the first 6 weeks, my breasts were full of milk and hurting, heavy, and I would cry under the shower, squeezing bread milk out. At the same time, my baby would be crying unconsolably. They were telling me his internal organs were developing, which is normal for all babies. But in my mind, I would think it's because he's not breastfeed. I would cry along with him. I would feel guilty that he wanted to be breastfed. I developed a depression. There is nothing painful than breast full of milk and a tiny baby crying. My partner encouraged me, and we decided to not breastfeed. My son is now 14 months old. I'm expecting another baby boy, and there's no chance that by March 2019 I will be able to choose to breastfeed. I'm doing this for younger generation of women living with HIV. We need healthcare providers to be on our side, not our police. There's nothing traumatizing than living in fear that someone may report you to child protection services. There's no proof that policing people living with HIV with criminalization laws have reduced the number of new infections. I think building trust and support for women living with HIV and providing information is key in protecting children to get HIV. Thank you.
Thank you, Claire, so much as well. As everyone can hear, this, is a very complex topic, and we're going to hear more about what research we have and what research we still need. But we really appreciate you sharing your story as well. And I sincerely apologize about this non-chat situation, because normally I know we have a lot more activity from our participants to get reactions and their feedback. We are seeing the questions come in, so we can kind of put those into the chat. If you want to put a question in, or a comment into the questions, I can copy and paste those into the chat and send that out to the group. So next, I am going to introduce Lena, and if you want to please just give a brief introduction of yourself, that would be great.
Yeah, hi everybody, and thank you to Claire and Jessica for sharing those stories. it's heartbreaking to hear stories like that. And also, Jessica, it's very encouraging to hear stories like yours. And I think it's really important that women are supported to make informed choices. So my name is Lena Serghides. I'm a basic scientist. I work at Toronto General Research Institute in Toronto, Canada. And I've been working on HIV and pregnancy and the safety of antiretrovirals in pregnancy for the last 7 years now. And I've been doing a lot of speaking about risk of HIV transmission through breast milk and trying to explain the science that we have as it is right now in a way that's approachable and easy to understand. So I have control now, right? Okay, so let's see if this works. Okay, here. So there's a big question. Can I breastfeed if I'm living with HIV? So choosing how to feed your baby is one of the most important decisions that expectant and new parents make. And it's a very important decision. And it has to be made for the best outcome for the entire family. And this decision can be very complicated when it comes to a family that's living with HIV. Okay, let's see. Okay. I'm sorry, the slides are not. There's a bit of a delay.
Not moving.
Not moving. Do you want to take over, Krista?
Sure. Okay. Here you go.
All right, thank you. So when a woman is living with HIV and has an undetectable viral load, and what does that mean? So that means that the woman is taking antiretrovirals, and when you do a blood test, there's so little HIV that you cannot detect it. So that's called an undetectable viral load. So in this case, there's actually a zero risk that she will transmit HIV to her sexual partners, and we have very, very solid scientific data to support this statement. And it's great to live in an era where we can say this. So it's slightly different when it comes to pregnancy and breastfeeding. So the risk of transmitting HIV to her baby when a mother has an undetectable viral load during pregnancy or birth is actually very low. So we can get it almost close to zero, but we definitely say it's less than 1%. It's slightly different when it comes to breastfeeding. So we're breastfeeding, we know that if the mother has an undetectable viral load, the risk is low, but it's not zero. So, and this is important to contrast it. So while the risk of HIV transmitting to the baby through breast milk when the viral load is undetectable is low to zero, it is low, but it's not zero. And this is different from the case for sexual transmission. So, and guidelines use the data that we have, such as it is, to make recommendations. And guidelines, as we heard from Claire say, that guidelines differ based on where you live. And the guidelines, their aim is to ensure that there's the best chance of survival, HIV-free survival for the child. So what does that mean? It means that the child has the lowest risk for not getting HIV, but also has the best chance of surviving in the first 2 years of life. So if you're a woman living with HIV in a resource-limited area, the World Health Organization recommends that you breastfeed if you are a woman that's taking HIV drugs. Now, if you're a woman living with HIV in a resource-rich region, like the US or Canada or Europe, treatment guidelines recommend that women avoid breastfeeding. So the reason is because in resource-limited areas where clean water may not be available, refrigeration may not be available, good medical care may be limited, and access to formula may be limited. And we have a higher chance that children may get diseases like pneumonia or diarrhea, where they can suffer from those. Then the protection that breast milk gives is a benefit that exceeds the low risk of transmission of HIV. But this is opposite to research-rich countries where we have access to affordable formula, or we may have access to affordable formula. We have access to clean water and medical care, when the risk of HIV transmissions becomes the more important issue to think about. So, but some parents in research-rich areas still want to consider breastfeeding despite these guidelines. And this process of deciding how to feed your infant can be overwhelming for parents who are living with HIV. And it is important that parents get all the information to make an informed choice. So breast milk is one of the fluids that can transmit HIV. So this is along with semen and vaginal and rectal fluids. What's a little bit different about breast milk is, unlike those other fluids, when a baby breastfeeds, they receive a very large amount of breast milk. So it's about 150 liters over the breastfeeding period. So that's much more a volume than semen or vaginal or rectal fluids. So, and what's different about breast milk is that you could have undetectable viral load in the blood, but this does not guarantee that you'll have an undetectable viral load in the breast milk. The two things can act separately, like your blood viral load in your blood can be different from your viral load in your breast milk. And what's the other thing about breast milk is that breast milk has a lot of immune cells in it, and immune cells can carry HIV virus in them. And the HIV virus is called cell-associated virus, and this virus is not susceptible to the HIV drugs. Another thing is that HIV, sorry, let me see here. So we definitely need more research into how HIV drugs can get into the breast milk, how they affect virus in breast milk, and how they affect breastfed babies, because HIV drugs also can transfer into the breast milk, and then that will go into the babies. Now, the best data that we have comes from the PROMISE trial, and this was a large study among 2,000 breastfeeding women with HIV, living with HIV, and their infants. And this study was done in Africa and India, so this is a low resource setting. Now, in this study, HIV transmission rates to the babies were very low. They were, in fact, less than 1% following a year of breastfeeding. But the important information here is that we did have 2 infants in the study that acquired HIV from the mothers, while their mothers had an undetectable viral load right before the transmission happened. So another point of this study is that all mothers were on combination therapy, and some of the babies were on antiretrovirals as well. So there was 2 arms to the study. But the point is that the transmission was less than 1% with a year of breastfeeding, and we did have 2 infants that transmitted acquired HIV from the mothers with an undetectable viral load. So next slide. So a very good thing about breast milk is that it transfers the mother's antibodies to her baby. So breast milk is very good at helping the immune system of the baby. So by transferring maternal antibodies, we can protect the infant against common illnesses and allergies. However, HIV drugs, like other medications, are also passed on to babies through breast milk. So this transfer of antibodies and HIV drugs can protect the infant from acquiring HIV. But we don't know whether the HIV drugs that are passed on to the baby will have any long-term effects on the child's health, whether this transfer of drugs into the breast milk happens the same for all the HIV medications that we have. And we know there's different drugs that are used in low resource settings versus high resource settings. And most of the research that we have comes from low resource settings. And we also don't know whether the amount of HIV medications that transfer to the breast milk changes throughout the breastfeeding period. So there's a lot of research that still needs to be done. So next slide, please. So in the US and other research-rich countries, pregnant women are often told that breast is best. And this is something that's out there. But women living with HIV are also told that they should not breastfeed. And just as a point here, this is very strong for women living with HIV, but there's other women that have conditions where they're not allowed to breastfeed. So with modern HIV drugs, women's viral loads may be below detectable for a long time. So this has many women living with HIV wondering whether the advice not to breastfeed is still true for them. But because HIV guidelines in most resource-rich countries, actually all resource-rich countries, recommend against breastfeeding, we have not had any studies on breastfeeding that have been conducted in a research-rich setting. So, and we know that women in research-rich countries have different circumstances. Usually they take newer HIV drugs. They're more likely to have access to enough food and clean water. So it's unclear whether the information that we have from the research studies that have been done in low resource settings apply to the high resource settings. So next slide. So it's important to point out that in recent years, the guidelines from the US, from Britain, and from the UK, they recommend against breastfeeding when formula is available, but they all have included updates that acknowledge the desire of some women living with HIV in resource-rich countries to breastfeed. So while this is not a recommendation, these guidelines suggest that ways for providers to support the health of women who make that choice, as well as their babies. So for example, the British guidelines stress that there's an informed decision-making and support for parents considering breastfeeding. And in the US, advocates and clinicians are working to update the US guidelines to reflect these principles. And the same is happening in Canada as well. So, and I'm going to say, next slide, please. So the final point I'm going to say is about the undetectable equals untransmissible campaign. And this is the U equals U campaign, which is based on very solid scientific data that has shown that if a person takes their HIV medications and has a viral load that is undetectable, they cannot pass the virus through sex to their partner. But this U equals U, while it's great and it's based on very solid evidence, it does not really apply to breastfeeding as we know right now. There's still more research needs to be done, but as the data right now does not support U equals U for breastfeeding. And this is because the amount of HIV in breast milk and blood can be different, and lots of different conditions can happen that can affect viral load in the breast milk specifically. So while the risk of transmission through breastfeeding is low, when the mother's viral load is undetectable, it is not zero. And we actually have that PROMISE data that shows that 2 transmissions happened when the mothers had an undetectable viral load. Next slide. So while research into this issue does continue, it is important for care providers and other community health professionals to help women make informed choices based on the information we have today, and to provide support to those who choose to breastfeed their babies. So we need more research, but we definitely need to support women in making an informed choice that is going to be best for them, for their babies, and for their families.
Great. Thank you so much, Lena. This is very important information, and I hope I look forward to seeing what kind of questions and discussion comes up. We'll be posting the questions again that we have in the question box. We'll post to the chat so that everyone can see them. But thank you for that great presentation. And now I'm going to just make sure Jenell, Dr. Coleman has the access to the keyboard and can advance the slides. And if you want to give a brief introduction of yourself as well. Thank you.
Yes. Yeah, thank you. So good afternoon, everyone. First, I would like to thank the organizers and Jessica and Claire for sharing your stories. I'm just really happy that we're talking about this topic because I feel like the more that we can talk about it, we increase the awareness that this is something that's very important for women living with HIV. So my name is Jenell Coleman, and I'm an associate professor of OBGYN at Johns Hopkins. I've cared for women living with HIV for almost 2 decades now, and I've also done some clinical research in this area of breastfeeding among women living with HIV. I'm going to have to say next slide too. It's not working.
Sorry about that. Okay, here you go.
Okay, so for the next few slides, we will review guidelines in a bit more detail and discuss risks, benefits, and challenges of breastfeeding. So if you're a woman living with HIV in a resource-limited area, the WHO recommends that you breastfeed if you're taking HIV drugs. Their health authorities have determined that the benefits of breastfeeding outweigh the risk of HIV in these areas. So for the reason for this recommendation is that in such resource-limited settings, formula feeding may not be an option due to lack of funds to purchase it, clean water to mix with it if it's powdered, or refrigeration to keep it fresh. So in these areas of the world, infants are more likely to develop diarrhea and other illnesses and may die from these. Breast milk, however, as mentioned before, contains substances that protect and strengthen the child's immune system, even after they stop breastfeeding. So because of this, breast milk may help children to survive these health conditions. Next slide. If you're a woman living with HIV in a resource-rich area, such as the US or Europe, you've likely been advised not to breastfeed your babies. HIV treatment guidelines written by health organizations like the US Department of Health and Human Services, the European AIDS Clinical Society, and the British HIV Association all recommend that women living with HIV avoid breastfeeding. Infant formula, as well as clean water and refrigeration, tend to be readily available in these areas, and the chances of a baby dying from illnesses for which breast milk can provide protection is much lower. So based on the belief that the risk of a baby getting HIV from breast milk is not justified when parents can access safe alternatives, it was recommended to avoid breastfeeding in these regions. Next slide. However, there are some parents in resource-rich areas who may still want to consider breastfeeding despite the guidelines, and there may be many reasons behind this. So some women may be aware of the research showing that breast milk is best food for most babies, protecting a growing baby's health while satisfying all of their nutritional needs. There may also be emotional and cultural reasons why women may want to consider breastfeeding, even if they live in an area where formula is easily accessible. They may have pressure from their family to breastfeed. If they do not breastfeed, that may lead to disclosure of their HIV status. And then, as Claire had mentioned before, like women moving from like a resource-limited country to a resource-rich area may wonder whether or not, may wonder why there are different instructions and potential restrictions depending on where she lives. Next slide. Okay, so now we're going to move into some of the benefits. So the first couple of slides will be the sort of benefits for mother and the baby. So here are the benefits for the baby. So breast milk, we know, is the most nutritious food for babies and young children. It carries the mother's antibodies, which was mentioned earlier, which may protect babies from some illnesses and allergies. We know that breastfed babies have a lower risk of diseases such as type 2 diabetes and obesity later in life. And then there's the cost, availability, and convenience. Breast milk is free. It's readily available whenever the mother is with the baby. It can be expressed or pumped and fed to a baby in a bottle when she's not nearby. Next slide. For a mom, there are several benefits. One important one is bonding. We know that breastfeeding may help new mothers to feel close to their infants. Also, in terms of mental health, breastfeeding can help new mothers avoid postpartum depression, which can be pretty serious and make it harder to care for a new baby. And then there are other maternal health benefits, including a reduced risk of breast cancer, ovarian cancer, high blood pressure, and diabetes. Next slide. However, there are risks and challenges, and there are challenges with breastfeeding even if you're not living with HIV. So for women living with HIV, one of the most concerns that we have is transmission, because we know that HIV can be transmitted through breast milk, which means that your baby could be born HIV negative, but then acquire the virus from their mother's milk. We know that this risk increases if a child is fed breast milk along with other forms of nourishment, so-called the mixed feeding, where the baby gets breast milk but may also get commercial formula or solid food. And that's why the WHO recommends that women in resource-limited countries only feed their babies breast milk for the first 6 months of their lives. We also know that breastfeeding, it's difficult. It can leave nipples sore or cracked. Breasts can become engorged, which are not only uncomfortable conditions for the mother, but can increase the risk of transmitting HIV to the infant. And then there are the other sort of breastfeeding challenges for all nursing mothers. So mothers, regardless of their HIV status, they struggle with breastfeeding if they're working outside the home or taking care of other children in their household. So finding the time and space to breastfeed may become more difficult. And then with adherence, if you are living with HIV, there's an added layer of complexity that involves adherence to taking your own HIV drugs, going to your own appointments, but also the appointments for your baby and the baby taking medication as well. Next slide. Continuing on with the risk and challenges, we also know a risk factor for HIV transmission through breast milk is when the baby has inflammation or irritation in its gut, and that can happen when a baby is vomiting or has diarrhea. And then, as mentioned before, one of the concerns of lots of mothers are the legal considerations. So depending on the settings, so in countries where clinical recommendations discourage women living with HIV from breastfeeding, there is a chance that a woman who chooses to breastfeed her child may be forced to face child protection authorities or even criminal charges. According to the HIV Justice Network, prosecutions of women living with HIV for alleged exposure through pregnancy, birth, or breastfeeding are known to have happened in several high-income countries, including the US. And then we think about disclosure. So in communities where everyone breastfeeds, choosing not to do so may signal to others that you're living with HIV, even if she hasn't disclosed her status. Next slide. Furthermore, women may face pressure from their families to breastfeed. Women have been reported being pushed to breastfeed their babies by their mothers-in-laws. And overall, like I mentioned before, there's a lack of support for breastfeeding. So in some countries, women find it difficult to breastfeed regardless of whether or not they're living with HIV. Breastfeeding in public may be stigmatized, and new mothers sometimes are expected to return to work outside of home soon after birth. Next slide. So here are some suggestions for women who make the decision to breastfeed. There are ways to make it safer. So we know again that breastfeeding can be challenging for all women regardless of HIV status, and despite the fact that many people equate it to being natural and with it being easy, we know that it's difficult. So it's important to have all kinds of support as a woman breastfeed, including providers and other professionals, as well as supportive family, friends, and community members. So the key here is to build a support team. I know that Jessica had mentioned her providers in her circle of care, and that is so very important. And it's important to start to identify this team during pregnancy so that things can be planned and everything in place, and the woman would be supported after birth. And then I have talk with your trusted healthcare provider about the decision to breastfeed. I know that may be challenging in some areas of resource-rich countries to find a healthcare provider that you can trust, but folks are out there. So asking knowledgeable people in your community or other professionals, including lactation consultants, for advice on some of the challenges one may experience while breastfeeding, like the cracked nipples, sore nipples, or a baby who's having difficulty nursing. And then it's very important that the woman take the HIV medication as prescribed, and this will keep the viral load low and make it far less likely that the baby will acquire HIV through breast milk. There may be additional viral load testing done while breastfeeding. There is no quite one standard across the nation. I know that different institutions may be following their patients differently, but there is a lot of surveillance that happens afterwards. And then making sure that the baby also gets their doses of HIV drugs as well. So additional drugs over and beyond the typical 6 weeks given to babies exposed to HIV may be necessary in terms of the number of drugs, but also the time frame that they should be administered. Next slide. Also, it's recommended to breastfeed exclusively, so that means no other forms of nutrition for the baby for 6 months. So mixed feeding and infant formula, we know that in resource-constrained areas has been shown to increase the chance of transmitting HIV to the baby. It's always good for moms to take care of their own health while nursing. That means eating enough healthy, clean food, clean water to drink, and resting. Taking good care of your breasts, trying to avoid engorgement, mastitis, cracked nipples. Again, finding people who will help you manage your stressors, because there'll be a lot of stressors after having a child. So that includes like taking care of the infant, healing your own body after having birth, the breastfeeding, dealing with your diagnosis of HIV. And then also to remember to seek help if you're feeling sad after having a baby, because there are many women that experience the postpartum blues or postpartum depression. Next slide. So in the UK, they have a clinic that serves women living with HIV, and they developed a tool called the Safer Triangle. And basically, this helps parents understand the risk of breastfeeding and how to manage those risks. So a woman is told to stop breastfeeding if she gets 1 point on the list. So no virus, that means only breastfeeding if the mother's viral load is undetectable. Happy Tums means only breastfeeding when mother and baby both have healthy guts, like the baby's not having diarrhea, vomiting, mom's not having vomiting or diarrhea that can impact the absorption of the HIV drugs. And then healthy breasts for mom, as I mentioned before, breastfeeding when you have nipples that are cracked and bleeding can increase the risk of transmission. So next slide. So we know that there are other options, like moms have options in terms of infant feeding methods. So here are 4 different methods that are listed. So we talked about infant formula, which we know is the safest option from the perspective of HIV, because it's the only way to guarantee absolutely no risk of HIV transmission. And then you have the milk bank. So depending on where you are, whether or not you have access to this. So this is when women who are breastfeeding produce more milk than they need for their own babies, and they may donate it to a milk bank. The milk bank screens the woman blood tests for infectious diseases before they can donate. And then this breast milk is donated to a mother, sometimes for a cost, depending on the circumstances, for that mother to use for their baby when they can't breastfeed. So we know that in theory, this is a good solution for women living with HIV who want to be sure that they will not transmit the virus to the baby and that their baby will be getting the nutritious element of breast milk. However, we do know that milk banks depend on donated breast milk, and they may not always have enough milk to give away. We know that there is some variability in terms of like the different women who pass on different antibodies. So this means that, babies may not get as much of a specific antibody as they would if they were always fed by the same woman who passes on only one particular set of antibodies. And then we have like wet nurse or cross feeding. And like I said, this used to be popular a while ago, but it's not so common today. But there are some paid wet nurses, or you can have an informal arrangement with a friend. Again, these women should be screened for infectious diseases. And this solution depends on the woman producing more milk than she actually needs. However, unlike a breast milk bank, the woman has to be near you and be in the same place for you to use this method so that your baby is fed when it needs to be fed. And then last, we have flash feeding. And this is something that requires a lot of effort. And it was developed initially for people in resource-limited countries who didn't have access to any of the other infant feeding options. And this involves mom expressing the breast milk, like using a breast pump, and then heating the milk to destroy the HIV that may be present in the breast milk. However, we also know that it may destroy some of the good components in milk as well. Next slide. So to sum it all up, and this is for women living with HIV, just knowing that you are the only person who should decide how your baby will be fed. So if you choose to breastfeed, it is important to find that network and a provider whom you trust and you can rely on for support, and ideally doing this during pregnancy. And then also keeping up with the healthcare exactly as prescribed, because there's going to be lots of medications for you, for your baby, and appointments forthcoming. And then knowing that making this decision can be challenging. You may feel fear, stress, even some sadness over any choice that you make in terms of feeding your baby. But as most important is to take care of yourself during this process. Next slide.
Okay, great. Thank you so much. I just saw a comment like, wow, and this is so interesting. So I know this is a lot of information, and really appreciate you going through it so well. And so now we are going to, I'm going to ask Shannon to come back on, and we're going to have a little discussion with the panelists, and then we'll get to some of the questions that have been coming through on the Q&A. And if anyone has any other questions, we'll follow up with those as well.
Great. Thank you all. This has just been amazing and profound to hear all of this information at one time and in one setting. And I appreciate so much work that has gone into getting these presentations together. Thank you. So the layout of the webinar was really specific, that we wanted to center the conversation around women's lived experiences and also make sure that we had the latest clinical nuance and what research is out there, and also what research we need before we went into what we hope is a real talk, which is the roundtable discussion. And so I want to return to Jessica and Claire before we start asking some specific questions that have come through from people who are listening, to see, Jessica and Claire, if you want to circle back to your comments from the beginning and make comments and or ask questions, or just simply have responses to the presentations that we've just heard.
This is Claire. I think the information that was given is really important, and it's informing what we should be doing, and it doesn't change my position of saying we need to be, we need a supportive system where we are not just, where we can express our preferences, our cultural beliefs, our needs and wants when it comes to breastfeeding our babies. I am aware of the risk, but I want to weigh in. That's my position. It's a lot of scientific terminology, and I would love a team of care providers to help me digest all the information you gave in more simpler words, in more simpler forms that I can assimilate and use it in my day basis. That's what I think.
Beautiful.
Thank you.
I hear you. Thank you for sharing, Claire. Jessica,
Yeah, I couldn't agree more, Claire. I think that I want to thank the presenters for such a easily accessible presentation when it comes to basic sciences, and it can be quite daunting, but this was it felt quite unbiased, and this is the kind of information that women living with HIV and beyond that, service providers and healthcare providers need to hear, because it is there are so many levels beyond the basic science. There's the social, cultural, and emotional realities that women living with HIV face, not to mention possible legal harm for choices of not supporting. And I say supporting, but it may be to breastfeed, but it can be just supporting to have a more than a 2-second conversation of, no, you can't breastfeed. What about, let's explore together what different options are for you. And I think there's a really great video by Dr. Mona Lutfi, who I actually worked with. She was my healthcare provider, well, one of them. And in it, she talks about how previously her sessions, when it came to women around breastfeeding, took about 5 minutes, and now they can take upwards to an hour, because the information is so rich and diverse, and it's not a simple yes, no. So I'm really excited to hear what others have to say.
Great. I think I have a few thoughts too as I was listening and taking notes, that really this is a conversation where everyone is living on the edge of what we know, and so we're creating the future as we figure out these next steps. I think it's important to acknowledge like the vulnerability and the fragility of all of that as we kind of figure out where we need to go. So a couple things I noted as we went through the discussion, and you don't know these things reviewing documents behind the scenes, right, or until you get in a real life conversation, but it's also reflected in both of your comments, is that I don't know that we have well articulated or outlined how women are existing within a system that fundamentally doesn't trust us in our decision making. And we see this play out in lots of ways beyond just the breastfeeding piece. But I think when it comes down to the nuance of the breastfeeding piece, even with super well-intentioned providers and super well-intentioned brochures and whatnot, a woman herself is living within a system that ultimately doesn't trust her with the decision making, with making complicated decisions. And so there's the ripple effects of what can happen if a woman makes a informed decision with her partner or with her provider, that there's still lots of other structural pieces at play where she can have consequences for the decisions that she makes. And the piece that I think really Claire illuminated and Lena brought up also in her talk, but it's really worth making sure we keep weaved into the conversation, is what are the cultural norms, depending on the country of your birth and where you live now, and how those pieces are different, but as well as we often talk about people in resource-rich settings as if everyone in those settings are resource-rich themselves. But in fact, women are making decisions who are not themselves resource-rich, in which there's structural racism and other social determinants of health and structural factors which really weigh into her decision-making. So with that,
yeah, thank you. I think that's a really important part, and I think that's, with Claire bringing it up, and I think that's one of the things that I wanted to maybe circle back to, is that, since this is an issue, and finding a support system, as we're saying, if this is a choice that a woman makes, may not be just that simple, and women may not trust, maybe they have a relationship with the provider but may not trust the nurse and the practice. And so I think Dr. Coleman, maybe you can speak a little bit to kind of some of the changes that you've made or that you've been working on, and and kind of the process that it's been to get, and share some of the experience that you have in your hospital and what you've done to get there.
Yes, so I can say it has taken several years. I want to say I started on this back in 2014, and it started as simply a research project trying to understand the choices that women make in terms of infant feeding. And I can say that as an institution, it was something that pretty much folks said I should not even discuss or bring up. And I can say I was quite surprised because, yeah, there were some of my colleagues whom I admire, and I was quite surprised how they felt. And they did not want me to even have a conversation with women living with HIV about how they would feed their infant. So that was 4 years ago. And I can say that I've had to meet with lots of leadership to try to bring awareness to this, because I knew that it was happening. I knew that women wanted to breastfeed and they were afraid to talk to their providers. I've even had some women call me to say that they didn't want to get pregnant because then they could not breastfeed their child. And so we would have those sort of conversations. And I can say after several years of still just being persistent and talking to women, we slowly came around. So there were many women actually who helped move this agenda forward, which I think is very, very important. It was the women living with HIV who kept talking about this when they came in for their prenatal care visits. So we had a string of women in a row who wanted to breastfeed. And I pretty much think that after maybe the third time, we convened as a whole institution a multidisciplinary seminar that had OB involved, it had the pediatricians, we had social work, we had the lawyers present, and the nurses on the postpartum floor and lactation consultants. And it was really interesting because I can say as a group, it seemed like most of the providers were very supportive. However, our legal team came out and flatly said, absolutely no, Hopkins will never support a woman living with HIV breastfeeding in the hospital. And I can say that conversation probably happened in 2017, so not so long ago. And then this year, again, women kept asking about it, so we convened another session. And this time around, the lawyers, they had done some research and started to look into this area. And they were like, okay, we see that this is a concern and that this is a real thing pretty much. So they softened their stance. And yeah, we had ethics committee sessions as well. And I was really proud to say probably within like last month, I was on an ethics panel, an ethics lunch about this topic. And we had some patients share their stories as well. And overwhelmingly, folks were very supportive of women who decides to make this decision. So as an institution, we realized moving forward that this is happening, and we our first patient, our first woman who wanted to breastfeed, she breastfed while she was in the hospital, which was great. So that was a huge barrier. And that happened probably in August of this year. So we're really excited about that, of having our first woman. And so the things that I've learned from this experience, one, just in terms of the lack of knowledge that lots of providers have. So we had some postpartum nurses who were like flat out saying they would not take care of the woman if she decided to breastfeed. And then we realized that a lot of the fear that healthcare providers had was just based on a lack of knowledge. Like they were not aware of the data that we have now. And I think after talking about it so much and increasing awareness, that they were like, oh, okay, so things are different. So that's why I was really happy with this webinar, because as I mentioned before, I think increasing awareness and letting the folks who are into data know about the data and the science behind it. And I think that can help support a lot more women around this issue is that once we talk about this more and get it out there, then I think that's a way to make great progress.
Thank you. Yeah, so that's a success story of someone working over, diligently over a period of years to make that option accessible. And so I think, there are providers and people in advocacy who are interested, to kind of help move, that needle in the U.S. and in other countries so that it does become more of an option. But there is a lot of work that needs to be done, and around providers' knowledge and even like working with Child Protective Services and having them, be on board. So I think that's an area that we have an evaluation at the end of this. The presentation we'll be sending out to everyone, and we would love for anyone who's interested to kind of be involved in that discussion to let us know. And that's a question on the evaluation. So I know there's several questions that have been coming in, and I am trying to just kind of get those into the chat box. Are there any other comments or questions from any of our panelists and speakers before we go to the questions? No? Okay. So I'm going to kind of start with some of the earlier questions. And I think the first one that came in, I think was Jessica, when you were, and I think this is kind of maybe a larger question and something we had spoke about during the webinar, but, our providers or the doctors that are, supportive are willing to medically share the process that they develop. So, I mean, Dr. Coleman just shared hers, but, is there a resource, or is there a way that we can kind of collectively create a resource of providers and networks of people that are supportive, so that if you have a doctor that isn't, that they can connect to? Does anything like that exist right now, or is that a need that we need to look into?
This is Shannon, and I can share that if clinicians in the U.S. have questions about breastfeeding, they could call the National Perinatal HIV Hotline. And I know that the hotline has shared protocol with providers before. And in fact, I worked with I was talking with the woman and supporting her, and the clinician was working with the hotline. And it was actually really a beautiful experience where both felt super supported, and there was a really positive outcome.
Great. So another one of the questions is, is why hasn't WISE research or have not addressed this or add an arm to the research that's going on? And that, in the MAC studies that have been going on longer than WISE, the research is looking from head to toe, and their research is what drives many of standard of care that are not conducive to all women. So, yes, I mean, is there, I think we asked this outside of the research that was done, that Lena, you had presented. Is there other research that is being done? I think, Dr. Coleman, you had mentioned about something that the NIH is interested, but if you can share any thoughts on current or future research.
Jenell, do you want to mention the study going on?
Oh, well, so there are a couple of things. So just being in the research realm, I just feel like things take a long time. So I thought there is Julie Levinson may be on the call, but there is an observational cohort that's happening right now in the US and Canada, where we are following, right now we're just looking at past experiences of women living with HIV who actually breastfed. And the plan is to turn this into a study going forward. So I feel like that's kind of one of the first sort of steps that at least collectively trying to link all the providers in the US and Canada together so that we would have sort of a group of women who are interested in this topic. And then I can say that, Shannon, you know more about this. So I was on a webinar earlier this year with folks representing some of the networks for HIV, and they had expressed an interest in this topic. Now, exactly what that interest is, I don't know. I don't know if it's from sort of the basic science standpoint or if it's clinical research, but I can say that when I talk to some folks that deal with women in HIV and NIH, that they have been saying this for a while. So I don't know what that exactly means, whether or not it'll turn into something, but
yeah,
Shannon.
well, we've had lots of discussions too about whether it's feasible to do these kind of studies in the US or in Canada or in Europe. And it kind of conflicts with, you can't say to a woman, well, you can't breastfeed, it's against the guidelines, but then, oh, give us your breast milk so we can do studies. But I think with this change in interest, maybe we can get, hopefully get some studies going to address some important questions that we have that are not answered yet. I'm not sure that we'll be able to do the kind of study like the PROMISE trial because we simply don't have that many women in the US or in Canada to build the kind of study that will have the power to answer what is the risk of HIV transmission when you're using the type of medications that we use in the US and in Canada. But there's definitely lots of questions that we can still answer.
This is Shannon. I can briefly chime in. So I think there's several different types of research that could be done. There's clinical trials, there's implementation, there's observational. And really the work that Dr. Coleman's doing right now is really going to pave a way for a lot of new knowledge to come out. And for that, you definitely need time, funding, dedication, but it's not the same thing as trying to get a clinical trial funded. So being able to show kind of the nuance and the challenge and then the practical implications of decision making can actually move this forward. If we had providers who were willing to write up cases in which they worked with women, regardless of what the outcome of that case is, but it was documented, that also helps to start to change things in terms of when there's legal issues or you want to have policy change or you want to show guidelines, a new way of going forward. Because even without those first steps, you're still with this vacuum of documented information for people who want to try to, change these things to be able to make decisions.
Yeah, it's a very good point, Shannon. And there's like you said, there's lots of information that we can get for other things. And one of the things that we've been working on is trying to get some information together to I want to say, standardize the way that the information is passed on to women that are interested. So that all the information on the research is passed on in a nice, digestible, easy to understand way. That we discuss all the things that are involved in the care management and what things you have to watch out for and what are your options. So this is a package that we're working on in Canada, and we will make it available very soon. I think we're hoping that it'll be done by the end of January, and then I can share the information with the Well Project, and it can get out to all of whoever's interested. And this includes also a video that explains the risk of HIV transmission through breast milk.
Great, thank you. And that goes along kind of with this next question that was asking about the studies that you presented, and we posted the link to one of them in the chat. I also just wanted to let everyone know, and this will all kind of come as follow-up materials, but we also have a fact sheet on this topic, and the slides were, essentially the information on the slides were largely pulled from that fact sheet. So if you go to our website, you can find the fact sheet. It's kind of featured on our homepage right now, but you can also click and search engine, the search box on our website to look for breastfeeding or infant feeding. So, and then, and we'll add these resources that we're talking about also to the page that the webinar recording will be available, and the slides that were presented today. So another question that came up is, are there considerations for women living in resource-rich countries but are not resource-rich, for example, in the rural South?
This is Jenell Coleman. I think that's an interesting question, because I think when we say resource rich, I guess folks are assuming that all of our patients fall into that category, but I can say the majority of our patients do not. So even though, like, my institution is located in a huge urban area, there's still women who may not have access to all of their resources equally, but the considerations are the same. So if a woman living with HIV, like during pregnancy, it's still discussing some of these same options. And I'm not sure, like in like the rural South, and I know there's access to care, access to sort of expertise for infectious diseases may be limited, but whomever she's seeing for her HIV care can be the same provider that she follows afterwards. And I can say that even here, when we had our woman who actually breastfed and we helped her, in terms of finding a pediatrician, was a little bit challenging, because lots of pediatricians, again, were not familiar and didn't feel comfortable taking care of an infant who would be breastfed. But it just took a little bit of work on our end and linking up with community providers to say that, hey, we are here as a resource. So I'm thinking like the National HIV Clinicians Hotline that Shannon mentioned before is very useful to try to find providers who may not be local to where the patient is getting care.
I'm going to just jump in and add that this is a great question, which gets to this real practical application. Like, where does what happens when you implement this? So because the breast is best and a lot of pro breastfeeding, which is awesome, that means there's a lot of resources public resources that are given to women who are breastfeeding that may not be given to women who don't breastfeed. So this can impact women who need WIC, for example, and there's higher WIC benefit given to women who breastfeed rather than women who don't. So I think all of these things need to be brought out when we're thinking about what happens when those ripple effects of what happens when you share information with women and then want to help them make an informed choice. And then also for us to think about in terms of the structural issues that need to change so that it's actually a fair decision that is made.
Hi, it's Jessica. I just wanted to chime in for 1 second. I think that's a really great question around access to resources, because in a consultation that I was part of with women living with HIV, it was global, and one of the questions that came up is what happens if you're in an emergency situation, for instance, a natural disaster, flooding, hurricane, earthquake, and so on, conflict setting, and you've been told not to breastfeed, and now there's the situation changes and there's not actually access to clean drinking water. How can you breastfeed, and will you be supported or still be seen as she put it, as a criminal? And I think that this is something that often we don't think about, is what happens in precarious settings when it comes to resources or in environmental or conflict situations. And can our ideas around infant feeding change?
Thank you. So there was a question, and some of it was answered through the chat, but just kind of but there was some secondary discussion around it, which I don't think made it into the chat. So just kind of talking a question around, what types of medications are administered to the baby after birth, and talking a little bit about that.
Hello, this is Claire. My baby was given AZT, and it was in a form of liquid syrup. So that's what he took when he was born for the first 30 days, I think.
Okay.
Yeah, sorry, I was muted there. So in Canada, the protocol is that a baby receives 4 weeks of a single. It's just one HIV medication. Often it's AZT, but it can be other things as well. So for 4 weeks, and that's to help protect the baby from HIV transmission that could happen during delivery, because delivery is a messy, bloody process. So there is a risk of transmission during it, and that's why they give that medication. A baby that is going to be breastfed in the Canadian setting, I guess, will probably be put on likely more than one HIV medication during the breastfeeding period.
And so I can say that in the US, I don't necessarily think that it's standardized in terms of the number of HIV meds that the baby would be placed on. So definitely AZT. And I know here at our institution that we are placing babies on both AZT and nevirapine during the time of breastfeeding. However, we talk a lot about this because there are no standards. No one knows whether or not you need that second agent. And then another concern with just the babies is that there's a limited number of antiretroviral therapy medications that they can actually take. So we've had discussions with our PEDS ID folks multiple times, because depending on who you talk to, like baby may be on one med or two meds. So it's something that part of the sort of cohort study that we're doing across the nation is to kind of look at the different regimens that the babies are placed on and for how long.
Thank you. And then there was a couple questions around, the need for more information and less judgment. And there was a question or a comment from someone saying that she works in a community organization supporting women living with HIV, and when they discuss infant feeding with women, it sometimes takes a long time to discuss all the information and details, and sometimes women come back for a number of appointments to continue the discussion. For some women, the decision is very clear and quick, and some women need lots of support to formula feed, some need support to breastfeed, others need some support but not a lot. We need to meet women where they're at, and we need to make sure that as service providers, we remain neutral and provide women with all the information about risks and benefits of breastfeeding as well as formula feeding. We can't assume that all women will want to breastfeed. And, I think it's a very important point, and I think, that's, again, when we kind of talk about, breastfeeding being complicated, like even without HIV being in that picture, I think many women who, are going through that process or even choose to breastfeed and have difficulties. So I think that has to be definitely, up that neutrality and trying no judgment across the board is an important point. I don't know if anyone wants to respond to that, or I'll go on to the next question or comment. Okay. Yeah, and someone else was just commenting about, Jenell, when you were talking about how you were surprised to hear the bias that you received from others and other providers around infant feeding, and someone was saying that's what they're finding out at their hospital in Toronto, and especially around people's making decision to breastfeed, and how much outdated information and judgment is still out there amongst providers. And I think that is kind of the crux of us really working on this topic is to start raising the awareness and start figuring out ways that we can maybe address that lack of information and bias. So let's see if there's any other questions. So another comment was, I'm happy to hear some options are being touched upon as nursing for many new parents may be therapeutic and healing. This focus is far beyond just feeding your baby. Let's explore chest feeding, skin to skin, and other methods which support new patients along this journey. I've had clients who smoke being told that they could not breastfeed. Let's continue our journey to provide evidence-based info rather than infringing opinions presented as fact. What if we did not make the decision for new parents, but rather support them, provide options, and acknowledge their feelings? So again, I think that comes back to this importance of information, awareness, and decreasing stigma and bias. And another comment was just that providers need more information around breastfeeding in general, even without HIV in the picture, but that's not often an area of training. So yeah, I think the rest. What are? Sorry. Okay. That question came in after kind of about the consequences of not breastfeeding, and does it have any effect on the babies? And I think we covered that kind of in the presentation. You know, and I don't know if anyone has any additional comments around not breastfeeding and the effect on babies. I mean, I think we're talking more about the positive effects of breastfeeding on the mother and child, but not necessarily the other way.
We have a brochure at HIVE called Bonding with Your Baby Without Breastfeeding. And I think while there's so much research showing the positive effects of breastfeeding, that's without also sharing that for lots of reason women don't breastfeed. It's hard. There's other medical conditions or personal conditions that keep that from happening. And those are also awesome women who are bonded with their infants, and these infants are thriving and healthy. So I think we need to make sure that we share both sides of that story, and ultimately that women feel empowered with whichever decision. And mind you, women might change their mind to do this and then to do this or to that. That throughout it, that we're supporting them and making these choices that are best for themselves and their babies, and that them and their babies are going to be okay.
That's a very good point, Shannon. And just is information, formulas have gotten better over the years, and now there's formulas that are being supplemented that have things like DHA in it that helps brain development. So they are trying very hard to improve formulas to try to mimic breast milk as best as they can. Of course, formula is never going to provide the immune benefits that breast milk does, but a lot of the other things that of the breastfeeding process, like the skin-to-skin touch and the connection with your baby, you can get that through other means as well.
Thank you both for those comments, and I think that's a really important point. And I know we're at our time, but before we end, I want to first thank everyone for amazing presentations. I want to let you know that, again, we'll be following up with all this information after the webinar. But I also want to just hand it back over to Claire and Jessica to, share any final words with our group. And again, thank you to all the presenters and speakers. You're all amazing.
This is Claire. I am so thankful for this presentation, and I thank all other presenters. And I think we need more awareness, and we need to have a presence on the web, a presence in the news, so the issue of breastfeeding while women live with HIV can come up as important. and I think we have a support. And also the other thing we need to flip the healthcare providers who are on the other side, who are not supportive. How are we going to do this? It's a collective effort to make sure they understand where we are as women living with HIV, and where the researches we have. And thank you.
Thank you, Claire.
So, yeah, thanks, Claire. I start on a really personal note, and I'll end on one. So, the last, I guess, 3 years of dealing with the breastfeeding and advocating have actually been like incredibly difficult for me. And I share that because making the decision is not a light one, and especially for women who choose to do it, even with support from healthcare providers and a team around them. But before I started this webinar, because last minute I didn't want to do it, I looked at this one picture of me where I'm wearing red lipstick, and I was able to, football style breastfeed both my twins at the same time. And it's one of like the most beautiful and empowering moments of my life. But it was also just as beautiful and empowering to see my lovers with 2 bottles of formula and able to feed the twins at the same time. So I say that in whatever decision that a woman living with HIV chooses, make it be hers, and it's the right one for you.
Okay, well, I don't think we could end any more appropriately than that and beautifully. Again, thank you all for sharing, Claire and Jessica for personally sharing your experiences, and then Shannon, Lena, and Jenell for your expertise and all the knowledge you bring to the table. And we look forward to continuing this conversation. This is kind of the beginning of, our wanting to really figure out how we can move this conversation forward and increase awareness. So thank you, everyone, and for participating, and we hope you have a great holiday season, and Happy New Year.
Happy New Year.
All right. Bye, everyone.
Bye.
Bye. Thank you.
Thank you.